Good afternoon, everyone. It's 3 p.m. local time here in Ghana, and we welcome you to today's presentation, courtesy Ghana Medical Health and the Department of Medicine, Upper West Regional Hospital. Today will be led on the topic infective endocarditis by Dr. Opon Collins. We wish to do this in about 45 minutes, and then we allow about 10-15 minutes of discussion, and hopefully by 4 p.m. we should be done on this topic. As always, a few housekeeping rules to observe. You notice that when you get in, you are muted automatically. You will not be able to unmute yourself until at the end of the presentation. When, if you do have a comment, a question, or any as such, you can electronically raise your hand, and then I would allow you to speak so that we're able to keep within the time. It would be great if you make very good use of the comment session so that then whilst the presentation is ongoing, if you have any comment, any question as such to make, you could type in the chat box, and then we could address this at the end of the presentation to allow for maximum time for discussions and for the presenter to be able to finish up with the material. So without much ado, I would invite Dr. Collins Opon to lead us with the presentation. Dr. Collins, over to you, sir.
Thank you, boss. Thank you very much. I'm Dr. Opon Collins, and I'm presenting on infective endocarditis. Of course, my supervisor is Dr. Dominic. Okay, this will be my outline. Okay, so the term infective endocarditis, note infection of the endocardial surface of the heart. Infection involves heart valves, most commonly, but may occur within a septal defect, the chordae tendina, or in the mural endocardium. Infections of arteriovenous shunt, arterioatrial shunt, that's the patent ductus arteriosus, or coarctation of the aorta, are clinically and pathologically similar to infective endocarditis. So the main lesion of the infective endocarditis is the vegetation, which has a variably sized mass within inflammatory cells, the platelets, the fibrin, and the abundant immersed microorganisms. Infective endocarditis is defined as an infection of the endocardial surface of the heart, which may include one or more heart valves, the mural endocardium, or a septal defect. The intracardiac effects include severe valvular insufficiency, which may lead to intractable congestive heart failure and myocardial abscess. Infective endocarditis also produces a wide variety of systemic signs and symptoms through several mechanisms, including both sterile and infected emboli, and various immunologic phenomena, and has an overall mortality rate of 30%. The prevalence. The incidence of infective endocarditis in community-based studies ranges from 5 to 15 cases per 100,000 per annum. More than 50% of patients are over 60 years of age. In the United States, the incidence of infective endocarditis is approximately 12.7 cases per 100,000 persons per year. And then previously, 50 years ago, it was 2 to 4 cases per 100,000. The proportion of patients with intracardiac devices has also increased from 13.3% to 18.9%. In Canada, the incidence of infective endocarditis in population studies ranges from 1.7 to 6.2 per 100,000 persons per year. In the United Kingdom, from 1998 to 1999, the overall case was 26.6 cases per million, which is 2.66 per 100,000 people per year. In 2009 to 2010, it's now 26.9 cases per million. And then from 2018 to 2019, we now have 50 cases per million, which is 5.0 per 100,000 people per year, with an increase of 86%. So this is our normal heart valves. We have our tricuspid valve here, the mitral valve, the pulmonic valve, we have the aortic valve too. And this is a prostatic valve. We have our vegetations, as we can see here. So let's move to the classification of infective endocarditis. We have the native valve endocarditis, which could be acute or subacute. We have the prostatic valve endocarditis. We have early and the late. We have the intravenous drug abuse endocarditis. We have left-sided and the right-sided. We have the pacemaker infective endocarditis. We have the nosocomial and the healthcare associated. So for the acute native valve endocarditis, usually involves the normal valves and has an aggressive cause. The underlying structural valve disease may be absent. And of course, usually the underlying organism is Staphylococcus aureus or Bubis streptococci. We have the subacute native valve. That's what typically affects only abnormal valves. It may extend over many months, usually in the setting of underlying structural valve disease. We have the prostatic valve endocarditis, which accounts for 10 to 20% of cases of infective endocarditis. The early one occurs within 60 days of valve implantation, and usually the coagulase negative staphylococci and Candida species have been the common infecting organisms. We have the late prostatic valve endocarditis, which also occurs 60 days or more after valve implantation. We have the intravenous drug abuse endocarditis. 75% of cases of intravenous drug abuse endocarditis has no underlying valvular abnormalities. And then 50% of this kind of infection also involve the tricuspid valve. We have pacemaker infective endocarditis, which also has 75% being produced by staphylococci and the coagulase negative and coagulase positive. We have the nosocomial infective endocarditis and the healthcare associated. The nosocomial one is defined as an infection that manifests 48 hours after hospitalization, or that is associated with a hospital or on the basis of a procedure performed within 4 weeks of clinical disease onset. The term healthcare associated infection endocarditis is inclusive of all sites that delivers patient care, such as the hemodialysis center. Staphylococcus aureus has been the predominant pathogen of this kind of infection. So in summary, we have native valve endocarditis, which account for 78%, and we have the community acquired, the healthcare associated, and the intravenous, which is we have the right and the left. Where the healthcare associated, we can have the nosocomial and the non-nosocomial one. We have the prostatic valve endocarditis, accounting for 17%. We have the early, which is less than 2 months. And then we have the mid-term, which is 2 to 12 months. And then we have the late, which is more than 12 months, accounting for 13%, which is the most common. Then we have pacemaker and defibrillators. So this a chart showing native valve endocarditis, how common they are. So let's move to the risk factors of infective endocarditis. So we have the cardiac conditions and the comorbidities. So we have a valvular heart disease, the congenital heart diseases, a previous endocarditis, presence of prosthetic heart valve, implantable cardiac defibrillator, patient with implanted cardiac devices, that is the permanent pacemakers and the implantable cardioverter defibrillator. The comorbidity, we have the intravenous drug user, we have increased maternal age, dental procedures, chronic kidney disease, who will be moving to hospital for dialysis, advanced age, more than 60 years, the use of steroid, fully controlled diabetes, indwelling line for venous access, and the immunocompromised patient. The etiology. So organisms causing major clinical forms of endocarditis. We have Staphylococcus aureus. This infection is the most common cause of infective endocarditis, including both the prosthetic, the acute, and the intravenous drug abuse endocarditis. So approximately 35 to 60.5% of staphylococcal bacteria are complicated by infective endocarditis. The mortality rate of this is 40 to 50%. We have the Streptococcus viridans. The organism accounts for approximately 50 to 60% of cases of subacute disease. We have the Streptococcus intermedius group, also account for 15% of the cases. We have the non-enterococcal group D organisms. The clinical cause is subacute, and they're also sensitive to penicillin. We have the group B streptococci. So the acute disease develops in pregnant patients and older patients with underlying diseases such as diabetes and the rest. The mortality rate is 40%. We have group A, C, and G streptococci. Also, the group A organisms, they respond to penicillin alone. Okay, so I'm having a problem with my piece. Okay, let's move on. We have the coagulase negative Staphylococcus aureus. This causes subacute disease, and it accounts for approximately 30% of prosthetic valve endocarditis cases and less than 5% of the native. We have Pseudomonas aeruginosa. They also usually causes acute infections. We have the hazard organisms, the Haemophilus aphophilus. We have the Agrigotibacter species. We have the Cardiobacterium hominis. We have Echinella collodens. We have Candela kengai. These organisms usually cause subacute disease, and they account for approximately 5% of infective endocarditis. And they are also the most common gram-negative organisms isolated from patients with infective endocarditis. We have the fungi. They also cause subacute diseases. The most common organism of both fungal NV and fungal PV is the Candida albicans. Other causes are the SLE, which causes the Liebman-Sachs endocarditis and malignancies. So in summary of the etiology, we have staphylococci and streptococci accounting for 80%. And we have our culture negative. Sometimes you send a sample to the laboratory and it comes out negative because of antibiotic use before making a diagnosis. And we have these fastidious organisms. Example is the Bartonella species, the Brucella species, the Coxiella pernati, which causes the Q fever, and the Tomadophila stasi. We also have the hazard, as we have already discussed earlier on, and the Tropholema crypta, which causes the Hooker's disease, and the fungi. So pathophysiology. All cases of infective endocarditis develop from a commonly shared process as follows. There's a bacteremia, nosocomial or spontaneous, that delivers the organism to the surface of the valve. Then there's an adherence of the organisms, eventually invasion of the valvular leaflet. The normal cardiac valve endothelium is resistant to colonization by bacteria. Endocarditis is the result of the interaction among the host factors that predispose the endothelium to infection and the circumstances that lead to the transient bacteremia and the tissue tropism and virulence of the circulating bacteria. So usually there is an abnormal valve which causes a turbulent jet of blood flow. With time, the turbulent jet of blood flow will damage the endothelium. And when the endothelium becomes damaged, there's a platelet which comes together in order to heal. Later, they will clamp together, and then they will further adhere to damage the endocardium. So this one, when this form, this one will form non-bacterial thrombotic endocarditis because at that time there's no bacteria in it. So let's say through a dental procedure, you have a trauma in the oral cavity and bacteria enters the bloodstream. Then some of the bacteria, they have dextran that they can use to adhere to the platelets. And then this vegetation formed will include microbes. So bacteremia can also result from various invasive procedures. We have dental extractions, which has a rate of 40 to 100%. We have transurethral resection of the prostate, also has a rate of 20 to 40%. Endoscopy has 0 to 20%. Colonoscopy has 0 to 20%. Barium enema has 0 to 20%, and transesophageal echocardiography also has a rate of 0 to 20%. The primary portals are the oral cavity, the skin, upper respiratory tract, gastrointestinal tract, the genital urinary tract. So let's move to the clinical presentation. The symptoms we have, most common one is fever, followed by chills and night sweat, nausea, weight loss, and malaise. Arthralgia and myalgia also, they account for about 15 to 30%. We have back pain and others like headache, shortness of breath, and cough. So physical examination, usually a heart murmur is being picked up about 80 to 85%. They come with murmurs. Then there will be a new or worsened, there could be a new or worsened redigant murmur, about 10 to 40%. Then there could be splenomegaly, clubbing, neurologic manifestations, and then also peripheral manifestations. Others, we have neck stiffness, hemiparesis, we have conjunctival hemorrhage, pallor, race, cardiac arrhythmia, pleural effusion, friction rub. So these are some of the peripheral signs that we can see. We have the road spot, which is seen most commonly in acute bacterial endocarditis. It's a red spot caused by hemorrhage with a characteristic pale white center. We also have the splinter hemorrhages. We have our genuine lesions, which are also painless, erythematous, hemorrhagic or pustular lesions, often seen at the palms or soles. We have the ocular load. The ocular load, these are also painful. In fact, that can be seen in the fingers. So these are the peripheral manifestations we've already discussed. And then we have non-cardiac manifestations. This one we've already. Okay, so let's move to the investigations. So blood culture is a crucial investigation because it may identify the infection and guide antibiotic therapy. So 3 to 2 bottle blood culture set separated from one another by at least 2 hours should be obtained from different venipuncture sites over 24 hours. If the cultures remain negative after 48 to 72 hours, then 2 or 3 additional blood cultures set should be obtained. And the laboratory should be consulted for advice regarding optimal culture techniques. And usually the first 2 specimens will detect bacteremia in 90% of culture positive cases. Then we have our PCR, which is usually done for the Bartonella species and the T. papilla. So our baseline investigations, of course, our normal FBC. And then usually that one we show, FBC, we show normocytic pneumochromic anemia, which is commonly seen in subacute endocarditis with leukocytosis. and neutrophilia. So ESR is always elevated in about 90% cases. Then our electrolytes, creatinine, and then blood urea nitrogen must be done. The C-reactive protein, also a measurement of the serum CRP, is more reliable in monitoring progress of infective endocarditis. Then our urine RE, we have to do our urine RE. Then there will be proteinuria and microscopic hematuria, also seen in 50% of the patient. Rheumatoid factor is positive in 50% of the patients, and there's also a decrease in the C3, which is the complement component 3 and 4, and then the total hemolytic complement. Echocardiography, that is both the transthoracic echocardiography and the transesophageal echocardiography must be done. So the echocardiography confirms and measures vegetation, detects intracardiac complications, and assess the cardiac function. Transthoracic echocardiography is non-invasive, and it can detect vegetations more than 2 millimeters in diameter in 65 to 80% of patients with a definite clinical endocarditis, and also for identification of valvular lesions in patients with native valve endocarditis. The transesophageal endocarditis echocardiography is the optimal method for the diagnosis of prostatic valve, the detection of myocardial abscess, valve perforation, or intracardiac fistula, and for the detection of vegetations in patients with cardiovascular implantable electronic device. Chest X-ray must be done. Also shows an evidence of cardiac failure and cardiomegaly. ECG may show development of AV block. CT scan of the head to be obtained in patients who exhibit central nervous system symptoms or findings consistent with a mass effect. That's the micro abscess of the brain. Ultrasonography, two-dimensional cardiac Doppler ultrasound testing provides information about the presence and size of vegetations, which helps in diagnosis and, to some extent, in predicting embolization. Let's move the diagnosis of infective endocarditis. We are using the modified Duke criteria for the clinical diagnosis of infective endocarditis. So we have the major criteria and the minor criteria. The major criteria, we have positive blood culture and evidence of endocardial involvement. For positive blood culture, we have 2 blood cultures positive for organisms typically found in patients with infective endocarditis. And then persistent positive blood cultures taken more than 2 hours apart. 3 or more positive cultures with first and last drawn over more than 1 hour apart. 2, we have the evidence of endocardial involvement. Positive echocardiographic findings of vegetations, abscess or dehiscence of prostatic valve, and a new valvular regurgitation. For minor criteria, when there's a predisposing heart condition or intravenous drug use, paresthesia more than or equal to 38 degrees Celsius, vascular phenomenon, major arterial emboli, septic pulmonary infarct, mycotic aneurysm, or genuine lesions. Immunologic phenomenon, that is glomerulonephritis, pustular nose, root spots, and the rheumatoid factor. Positive blood culture result not meeting major criteria or serologic evidence of active infection with an organism consistent with infective endocarditis, and a positive echocardiogram that does not meet major criteria. So for a diagnosis of infective endocarditis to be made, the definite endocarditis, you need 2 major or 1 major and 3 minor criteria. So for definite endocarditis, you need 2 major criteria or 1 major criterion and 3 minor criteria or 5 minor criteria. For a possible endocarditis, 1 major criterion and 1 minor or 3 minor criteria. For rejection of the criteria for the diagnosis of infective endocarditis, when there's a presence of a firm alternative diagnosis of the manifestations of endocarditis, resolution of manifestations of endocarditis after 4 or fewer days of antimicrobial therapy, no pathologic evidence of infective endocarditis at surgery or autopsy after 4 or fewer days of antimicrobial therapy. So these are vegetations, as you can see. So vegetation is composed of bacteria surrounded by a platelet or fibrin layer attached to the underlying endothelium. The characteristic site of vegetations within the heart, in the presence of aortic insufficiency, vegetations occur on the ventricular surface of the aortic valve or on the caudal tendon or papillary muscles. Let's move to the management of infective endocarditis. In the management of infective endocarditis, we need a multidisciplinary approach with cooperation between the physician, the surgeon, the bacteriologist, which increases the chance of a successful outcome. Any source of infection should be removed as soon as possible. For example, a tooth with an apical abscess should be extracted. Empirical treatment depends on the mode of presentation, the suspected organism, and whether the patient has a prosthetic valve or penicillin allergy. Antibiotic treatment for infective endocarditis caused by common organisms. We have streptococci, penicillin, sensitive streptococci. So we give penicillin G 2 to 3 million units IV 4 hours for 4 weeks. Then with ceftriaxone, we give 2 grams daily IV as a single dose for 4 weeks. And for vancomycin, we give 15 milligrams per kg IV 12 hours for 4 weeks. For relatively penicillin-resistant streptococci, we give penicillin G 3 million units IV 4 hours for 4 to 6 weeks, plus gentamicin 1 milligram per kg IV 8 hours for 2 weeks. For enterococci, we still use penicillin G 3 to 4 million units IV 4 hours plus gentamicin 1 milligram per kg IV 8 hours, both for 4 to 6 weeks. Then you can also use ampicillin 2 gram IV 4 hours plus gentamicin 1 milligram per kg IV 8 hours for both 4 to 6 weeks. Then vancomycin 15 milligram per kg IV 12 hours plus gentamicin 1 milligram per kg IV 8 hours, both for 4 to 6 weeks. For staphylococci, methicillin susceptible infecting native valves, no foreign device. We have oxacillin 2 gram IV 4 hours for 4 to 6 weeks, plus gentamicin 1 milligram per kg IM or IV 8 hours for 3 to 5 days. We have cefazolin 2 gram IV 8 hours for 4 to 6 weeks, plus gentamicin, that one is optional, 1 milligram per kg IM or IV 8 hours for 3 to 5 days. We can also give vancomycin 15 milligram per kg IV 12 hours for 4 to 6 weeks. For methicillin-resistant infecting prosthetic valves, staphylococci, that one we give vancomycin 50 milligram per kg IV, 12 hourly for 6 to 8 weeks, plus gentamicin 1 milligram per kg IM or IV, 8 hourly for 2 weeks, plus rifampin 3 milligram orally, 8 hourly for 6 to 8 weeks. And then for HASEC organisms, we give ceftriaxone 2 grams daily IV as a single dose for 4 weeks. And then ampicillin 2 gram IV, 4 hourly plus gentamicin 1 milligram per kg IM or IV, 8 hourly, both for 4 weeks. So therapy for endocarditis involving a native or prosthetic valve or other prosthetic material resulting from Enterococcus species caused by strains resistant to penicillin, aminoglycosides, and vancomycin. The regimen we give linezolid 600 milligram IV or every 12 hours for about 6 weeks, or you can give daptomycin 10 to 12 milligram per kg per dose. So clinical and echocardiographic features that suggest potential need for surgical intervention. For vegetation, there should be persistent vegetation after systemic embolization. Anterior mitral leaflet vegetation, particularly with size more than 10 millimeters. Then more than or equal to 1 embolic event during first 2 weeks of antimicrobial therapy, and increase in vegetation size despite appropriate antimicrobial therapy. For valvular dysfunction, acute aortic or mitral insufficiency with signs of ventricular failure, heart failure unresponsive to medical therapy, for a valve perforation or rupture, perivalvular extension, valvular dehiscence, rupture or fistula, new heart block, large abscess or extension of abscess despite appropriate antimicrobial therapy. We still move on with the indications. We have surgery will be required for when there's a surgery will be required for optimal outcome. Moderate to severe congestive heart failure due to valve dysfunction. Partially, this is unstable prosthetic valve, persistent bacteremia despite optimal antimicrobial therapy, as we've already discussed earlier on. Let's move to the complications of infective endocarditis. We have myocardial infarction, pericarditis, cardiac arrhythmia, cardiac valvular insufficiency, congestive heart failure, aortic root or myocardial abscesses, arterial emboli, infarct or mycotic aneurysms, arthritis, acute renal failure, stroke syndromes, mesenteric or splenic abscess or infarct. In prevention of infective endocarditis, approximately 15 to 25% of cases of infective endocarditis are a consequence of invasive procedures that produce a significant bacteremia, because only 50% of those who develop valvular infection following a procedure were identified as being candidates for antibiotic prophylaxis. Only 10% of cases of infective endocarditis can be prevented by the administration of pre-procedure antibiotics. Maintaining good oral hygiene is probably more effective in prevention of infective endocarditis. You can reduce the risk of infective endocarditis by maintaining a good oral health through regular professional dental care and the use of dental products such as the manual powered and ultrasonic toothbrushes, dental floss, and other plaque removal devices. So the American Heart Association periodically compiles recommendations for infective endocarditis prophylaxis. So these are my references. Thank you.
Great. Thank you very much, Dr. Opong, for the great presentation. You did so in about 30 minutes. So that's great. It does give us a lot of time to have a discussion or to address any concerns or pick up any suggestions that others may have. Just before we move on to that session, like I indicated, if you have any question that you would want to put up, the chat box is there that you could use. However, since we are now done with the presentation, if you want to electronically raise up your hand, you can do so, and then I will mute you so that then you could go ahead with your questions. As we always do, we would want to evaluate Dr. Opong's output with this presentation. So you realize that I've in the chat box, I've just put up a 2-minute survey that you could just click and then let us know how he did perform, and then the areas for improvement. Thank you very much for making time to do this. So going through the chat box, I get a question from, a comment from Sani. He says that thanks for a wonderful presentation. I couldn't join earlier, but I wanted to find out whether, so he wants to find out whether the minor and major signs are same as acute rheumatic fever. Okay, so he wants to know whether the criteria that you gave, that's the modified Duke's criteria, is it same as for acute rheumatic fever? Dr. Opong, do you have a response to that?
But that one, I'm not sure of that one. That is the same.
Okay, so for what you did mention, that's the Duke's or modified Duke's criteria that is used in diagnosing infective endocarditis. For acute rheumatic fever, like he was asking about, is entirely different. Typically, we use the Jones criteria, so they are different. It's not the same, and the parameters that you use are different. Despite the fact that we also have major and minor. So these are two different people who have probably brought up criteria for diagnosing two different things. And acute rheumatic fever is definitely different from acute infective endocarditis. Thank you, Sani. Yeah, so that's the only question I have in the chat box. I will still remind you, if you could kindly just click on the quick survey that I've put up in the chat box, just about a minute or two, you would be done. It's a yes or no response, so that we're able to evaluate Dr. Opong and our presentation for further improvement. Thank you for doing this. If you have any question, could you kindly put up your hand and then electronically, then I'll let you talk. I get a question from Famselom. Thank you for the great presentation. How significant is the determination of minimal inhibitory concentration in antibiotic therapy in infective endocarditis? Dr. Opong, do you have a response to that?
Because for the MIC, boss will honestly help me.
So for MIC in antibiotic therapy, obviously that is quite significant for infective endocarditis. Standard practice, there are a couple of things we do which is not standard practice anyway. Standard practice does say that each facility is supposed to ideally have your antibiotic protocols, i.e. infective endocarditis would have known our local patterns of resistance and all of that. And that's the bigger chunk of it, which obviously we don't do. MIC obviously is also very important in determining which antibiotic you're going to use for the treatment of the common organisms. Most of the times we follow what the standard treatment guidelines does do for Ghana. That in itself is quite inadequate since it just boxes everything together. Obviously, like you will see, the Cardiology Society is having a scientific session, I think this week. They started this morning. One of the things they are looking at is probably collaborating with the Ghana Health Services through the Ghana Heart Initiative, which we went for a program for to help to streamline these services. So for Amselom, this is quite important, as well as other important variables like local antibiotic resistance pattern per facility, ideally. But if not even as such, the whole country should have guidelines for so. Thank you for bringing that up, Famselom. We don't have any other question in the chat box. If anyone has any question, any comment, any suggestion, kindly electronically put up your hand. I would unmute you and then you can go ahead with your question. Okay, so whilst waiting for people, Dr. Opong, I would, in your reading, did you come across because I realized your last sentence in the presentation was about the periodic recommendations for antibiotic prophylaxis by the AHA, the American Heart Association. I was going to ask you whether you've come across such and what are their recommendations?
Well, for the recommendations, specifically, they said antibiotic prophylaxis could be given only for those going for a dental procedure and with an underlying cardiac condition specifically. And they were suggesting amoxicillin 2 grams before the procedure. So they have for the adult dose and children were like 50 milligrams per kg. So that's what I read. It was specifically for someone with an underlying heart condition who is going for an invasive dental procedure.
Okay. So other than the dental procedure, so usually there are two things, two broad headings. It's not just the procedure, but we look at procedure, what you are going to go through, and then the risk factor. So there's a personal risk factor, i.e. from the patient, or if you have a comorbidity that puts you at the risk, and then there's the procedure that you are going for. It's quite a long list of them. And so usually we advise that, especially the dentists do have the details of these. I asked because the recommendations have changed for a while now. It's not routine that everybody who is going for any dental procedure at all that we give antibiotic prophylaxis. What the evidence shows is if you would have gingival manipulation or anything that will involve the manipulation of the tooth as such, then those ones you may go ahead and then give the antibiotics. There are quite a long list of them. I'm sure those of us who are joining the presentation could have time to go through this so that then we would practice antibiotic stewardship. So we don't throw about so many antibiotics and then we end up getting a lot of resistant patterns. These are things that we should take note of. So there's the patient factor, that's what puts you at the risk, and then there's a procedure that you are going for. All right. I don't see any comments, neither do I see a hand up. So a quick one, just to remind you again that you could click on the link that I put up just to submit your comments, your suggestions going forward with these weekly presentations. I would wish to, okay, so we get another one asking, I think Dr. Matthias asks, how do I get access to the presentation since I joined late? Dr. Matthias, I just put up the link to getting the presentations. I've put it up again, so you could click on that and then you have access to this presentation as well as all our previous presentations this year. Thank you, Dr. Matthias, for joining us. In the absence of any comments, any question, I would wish to thank all participants for making time this week to join us with this, our presentation on infective endocarditis. Join us again next week, Thursday, as we look at another topics. The adverts will be put up in the various or on the various platforms as always. Till we meet next week, Thursday, take very good care of yourself and God bless us. Bye-bye. Thank you, Dr. Opong, for the wonderful presentation.
Welcome both.